I am absolutely thrilled to be here on your 10th anniversary to share some thoughts, some ideas. It's wonderful to be in a room full of crazy people, right? As I was just hearing, people who look at what is and imagine what can be and are every day working to make that happen. As Eddie was just saying in that last session, staying true to that vision, taking care of yourselves and making it happen is incredible. I want to extend my congratulations to David Edwards, to Carol Naughton, to Shirley, to everyone else on the Purpose-Built staff for a job well done. Congratulations to all of the community quarterback teams for making the transformation come to life. The transformations that will lead to a healthier future for so many. You understand at a core level the importance of collaboration, of engaging businesses and the nonprofit world, the community groups, those who work in the investment sector, coming all together to make community transformation happen. I'm really grateful to the original founders of Purpose-Built Communities for seeing that vision and putting the effort behind it 10 years ago to make this happen. At the Robert Wood Johnson Foundation, we believe in what you believe in. We believe in a different America. We believe in the link between health, well-being, and what takes place in communities. So there we're talking about stability and quality homes, jobs that pay a living wage, reliable transportation, high-quality education, and affordable, high-quality health care and prevention programs. And you knew this. It's been part of what you have been working on from the start. And I'm going to spend some time talking about why the nation's largest philanthropy focused on health is so excited about what you're doing. But just to begin, to mark this special occasion and to acknowledge the impact that you collectively are having on health and well-being in our nation's communities. It gives me great pleasure to announce that we're going to make an investment of $6 million to advance the work of the Purpose-Built Communities Network. And there's several things that we're hoping this will help you do. Part of the funding is to help build, now I have to stay clear to the words here so that I get it right. Okay, part of it is to build a knowledge-sharing platform where members can exchange their experiences and best practices with one another more easily, with an end goal of building a strong and well-connected community of practice. In that first session, I was hearing the importance of that, of being able to reach back to the Purpose-Built network and talk to other people who are struggling with some of the same issues that you are. Another part will go towards developing a communication strategy to help network members effectively discuss the complex issues that surround neighborhood revitalization with others. I've spent a lot of time as a communicator, and I know how important it is to raise awareness. And the interesting thing about communicating is you see somebody and say, wow, they're really good. They must have been a born communicator. Well, it's practice, it's learning, it's getting together and honing those skills so that you can talk about things that can be quite divisive. Words can build walls and they can also build bridges. And so talking about solutions to things like systemic barriers to wealth building, the risk of displacing existing residents, and structural racism, having communication skills will allow all of us to more effectively communicate about those things. A third part is going towards something that the Robert Wood Johnson Foundation puts a lot of stock in, and that's data and evidence. So we're going to be collaborating with Purpose-Built in a national advisory committee to design and conduct a research-based evaluation of the various ways that Purpose-Built communities have impacted neighborhoods and residents across the country. We know how important it can be to have that information when you're going forward and looking for resources and support for the work you're doing. Okay, so my mom said when you're invited to a party, it's nice to bring a gift, so that's the gift part. And now I want to transition and talk a little bit about our work and how it lines up with what you're trying to do. See, normally I really like to walk the stage, but I'm recovering from a bike accident, so I'm going to be using this podium and this stool instead. But It's really a little, my mouth is connected to my legs, and so it doesn't always work as well. So I want to share for you our vision of a healthier America, why we focus so intently on the issue of equity and systemic discrimination, and how we're using data tools to help cities and communities improve well-being. And why partnerships with purpose-built communities and partnerships with others is so critical to what we think of as success. So our founder, we were founded in 1972. Robert Wood Johnson II, he left his fortune to found a foundation focused on improving health and healthcare for all in America with a particular focus on the most vulnerable. And initially, our foundation was divided into a bucket of work on health, and on health care, and a bucket of work on public health. And we've had a lot of successes that we've contributed to over our history. We contributed in a big way to the development of the 911 emergency response system, smoking reduction, palliative care in America. We've done a lot around nursing leadership and mental health and obesity. And about 6 years ago, as a foundation, we came to a realization that if we truly cared about people being healthy and healthier in America, we needed to think about things in a different way. And let me explain why. In America, we spend over $3 trillion a year on healthcare. That's more than twice the level of spending per capita than the next highest country. But we don't get a return on that investment. In America, we lead sicker, shorter lives than people in other wealthy countries. Take a look at this life expectancy data. So this is comparing life expectancy in some of the wealthiest countries in the world. In Japan, life expectancy is 83.9 years. In France, it's 82.4. United Kingdom, 81. And in the United States, it's 78.8. And when you look at what drives health, it's not all about access to health care. It is important to have access to health care, but if you stop there, you're not going to be allowing people to lead healthier lives. When we think about where health takes place, it takes place where we live, where we work, where we play, learn, and worship. So we've embraced a vision that we call a culture of health, and it focuses on what takes place in those places. Positive exposures early in life. Safe, affordable housing in communities that have schools that meet the needs of every child. Access to nutritious food and safe places to play. Secure jobs that pay a living wage and the transportation to get to those jobs. A healthcare system that truly meets the needs of the people it serves. And removal of barriers to health caused by racism, sexism, ableism, and other forms of discrimination. I'm a general pediatrician by training, and I've had the good fortune to be able to volunteer in pediatric clinics in every job that I've had. And what it's allowed me to do is see how these other factors, these factors outside of the exam room, contribute to health. In Atlanta, I worked for 13 years for St. Joseph's Mercy Care Clinic up on Buford Highway, for those of you who are from Atlanta. And I remember this little boy, he was 4 or 5, and he wasn't gaining weight. And we'd seen him back week after week, and we did dietary histories, and we were tracking his weight. He just wasn't gaining weight, and we did some testing, it was all normal. It wasn't until the registrar developed a trusted relationship with his mom that she was willing to say to her that he just wasn't getting enough to eat. He was hungry. In America, this little boy was going hungry. He was an undocumented immigrant. He wasn't eligible for a lot of the programs that are available if you have papers, and he was going hungry. So we connected him to food banks and dealt with that issue. In New York City, I worked in Harlem in a clinic, and we saw a lot of foster care children. I remember this grandmother who traveled from Staten Island, a couple hours for us to see her grandchildren. And I had been at the CDC, and I went over the exercise guidelines, an hour a day, 5 days a week is what's recommended for children this age. And she said, I know the recommendations. I said, well, what are your grandchildren doing? And she says, it's not safe to go outside and play. So her grandchildren were on screens, but she knew what needed to take place for health. And in Trenton, where I work now in a clinic, a mom with a child with asthma who's in the emergency room once a month because her landlord doesn't want to pay the expense to clean up the dust mites that are triggering her child's asthma. You know, if you limit what the discussion on health to what takes place in that healthcare setting, we're not going to create that opportunity for health. At the foundation, we are focusing intently in all our work on equity. And I want to take a couple minutes to talk about equity versus equality. I see equity up there on the stage, and I love it. What we found is that there's often some confusion between the difference between equality and equity. So we came up with this graphic. So say you have a community and you want everyone to ride their bike. I feel less strongly about that given I had a bike accident, but say you want everyone to ride their bike because it's associated with health. Well, up at the top, everyone has the same bike, okay? And look what happens. You have the young woman on the left who is in a wheelchair. She can't use that bike. The tall guy like me, he can ride the bike, but he's going to end up with a really bad back after a while. The woman next to him is doing great. The bike fits her. She's able to ride. And the little kid, his feet can't reach the pedals. So in a situation of equality, you're not going to get the outcome you want. But if you look below, this is a situation of equity, where everyone gets what they need to be successful. So the woman in the wheelchair has an accessible bike. There's a tall bike for the tall guy. The woman still has that bike, and there's a bike that's appropriate for that child. This is what we mean by equity. People getting what they need to make that healthy choice, to make it successful. And when it comes to health and well-being, opportunities and barriers relate to all kinds of things. Income, gender, race, geography, physical ability, age, sexual orientation. It can go on as things that will either allow you to make healthy choices or make it much more difficult. You know, we heard in the first sessions discussions around the American dream. And when we think about equity, we think about it as opportunity. Everyone having a fair and just opportunity for health. And we talk about this being the land of opportunity, the American dream, but we know that as a nation, we have not lived up to that. The framers of our Constitution didn't live up to that. It's aspirational. And what you all are trying to do is make that dream come true. Our history has been filled with barriers set up, deeply rooted, so many times intentional, that continue to limit the opportunity for many. Some groups have a lifetime of benefits and opportunity and privilege because society has set it up that way, and others have burdens and barriers, nothing to do with how hard they work or how much education they have, because society has set it up that way too. You're going to be hearing from some terrific speakers over the next couple days. Richard Rothstein tonight. He is just doing an incredible job in raising up the record on the long and troubling history of discriminatory housing and zoning policies that intentionally segregated America, and how structural racism continues to limit opportunity. You're going to hear from Brian Stevenson, who's devoted his life to fighting ongoing racism in the American justice system. We have, at the foundation, learned a lot from both of them, and it helps to inform the work that we're doing. We know it's going to be a long time to remove the barriers to well-being that are so ingrained in society, and that's why we're fully committed to approaching every aspect of our work, keeping equity in mind. We continue to ask ourselves, what social factors are perpetuating the cycle of prejudice, isolation, and oppression? What policies can we help move forward to develop and to repair the damage? How do we work to change mindsets so that people think about health in a different way? Think about health as opportunity, health taking place in all of these settings. When I look at this room full of people, I feel like I'm talking at a public health conference. And I remember talking to Carol about this, and she said it took 10 years for the folks in Eastlake to admit that what was taking place was really a public health intervention. You know, everything that took place, and it wasn't until they saw improvements in blood pressure, improvements in people's blood sugars, improvements in people's body weight, was it clear that the transformation of community improves the opportunity for health. It was a beautiful thing. All right, so one of the things we love to do at the foundation is bring data to bear to these issues we're talking about. It's so easy to talk talk past each other. It's, even in this day, facts are being challenged, but we believe at the level of our heart that starting with facts can be important. And so that's one of the things that we do. One of the tools that we developed is something called the County Health Rankings, and many of you may know of the County Health Rankings. They've been coming out for 10 years, and what they do is they look at every county in America, and within each state they rank counties based on quite a number of health measures. So things like the rate of diabetes, smoking, obesity, teen births, premature deaths. But they also look at the factors that influence health and well-being. Things like employment rates, graduation rates, the quality of housing, the degree of segregation and poverty rates. These kinds of localized data are critical for local policymakers at all levels of government so they can understand the problems in their communities and make local decisions to how they want to address those. Well, last year, in 2018, for the first time, we broke down our data not just by place, but also by race. And the findings, they're not surprising, but they should be unacceptable to all of us in America. Health indicators for Black Americans, Latinos, and Native Americans were worse across the board than they were for whites, even if they lived in a county that ranked high in overall health. I'll just show a couple of these. So here's one. Across America, babies born to Black women are more than twice as likely to die in the first year of life as babies born to white women. This is CDC data. Too often, people will look at this data and say, well, it's really a reflection of, differences in income or differences in education level. Well, that's not the case. Here's some data from Brookings. And what this does is it breaks down infant mortality by race and education level. So the bars on the far left are for women with an 8th grade or less education, moving across high school, bachelor's degree, and advanced professional degree. For Black women, it's in blue. For white women, it's in green. And what you see is that the likelihood of dying in the first year of life is higher for a baby born to a Black woman with an advanced degree than it is for a baby born to a white woman with an 8th grade or less education. I mean, that should just be striking to see that and not ask why. What's going on here and how is this acceptable? And it doesn't stop at birth. Raj Chetty and his colleagues at Harvard have looked at upward mobility. And this is the likelihood that someone born in the lowest income quartile or quintile will make it up to the top of that economic peak. That's that idea of the American dream. We help support some of this work, and they looked at upward mobility for more than 20 million children. They broke the data down by race and family income. They linked census and tax data, so they were able to look intergenerationally over a span of about 30 years. And look what they found here. This is looking at children who were born in low-income homes. White boys were 4 times as likely as Black boys to achieve the American dream and climb the economic ladder. 4 times more likely. And then if you look at those who are born with that silver spoon, those born in the highest income level, white boys were twice as likely as Black boys to be able to stay at that level. The takeaway isn't surprising, but having numbers to be able to look at this, to shape a conversation, can be very helpful. We found it useful when we talk to policymakers, people in community development, and in private industry. It points directly to the impact that race and place can have on a person's opportunity to thrive. We know that discrimination has a big impact on health, and one of the things we wanted to do was explore the experience of discrimination in America in a bigger way. And so we support a survey every year with the Harvard T.H. Chan School of Public Health and National Public Radio. And so we asked them to take a comprehensive look at Americans' experience with discrimination. They interviewed people across the country on all kinds of topics: interactions with police, interactions going to the doctor, renting an apartment or buying a house, applying for a job or to college. 3,400 people took the survey: whites, Blacks, Latinos, Native Americans, Asian Americans, people who identify as LGBTQ. And let me just share one of the stories with you. So this is Laura and Gustavo. They're newlyweds. They live in Baton Rouge, Louisiana. And they decided that they wanted a bigger house than they had. And they saw one in their neighborhood that was for rent. So Gustavo called the real estate agent, and take a listen to what happened.
My name is Gustavo. I live in the neighborhood, but I'm interested in moving into another home, and that I was a young married guy looking for a place to live.
But he didn't hear back.
He called her back a week later, something like that, and she didn't return his call.
So after not hearing back twice,
I said, I don't want to make any assumptions here, but I was like, why don't you give him a call and see if you get a call back? And she left a message saying, this is Laura, I live in the neighborhood, just kind of a similar message.
And when I called and said my name, which sounds very white, the woman texted me back like within 5 minutes.
And we just kind of looked at each other, and I kind of started, laughing. Hey, this kind of stuff happens all the time, but she got really upset.
I had a much stronger reaction. I was livid. The only different information she had between the two voicemails were our names.
So that's just one example of a story. National Public Radio did 30 or 40 stories coming out of this poll, exploring different aspects of discrimination. What they found in the survey was that every group experiences some degree of self-perceived discrimination. Nearly 1/3 of Latinos and 1/4 of Asian Americans say they've been personally discriminated against when applying for jobs, being considered for promotion, or asking for equal pay, or like Gustavo when trying to rent an apartment or buy a house. Among African Americans, that number jumps to more than 55%. And 60% of black people said they or a family member has been unfairly stopped or treated by the police because they're black. One of the areas we care deeply about at the foundation is in the healthcare system. And while a percentage of every group says they've been discriminated against, 1 out of every 3 black Americans, 1 out of every 5 Native Americans and Latinos say they've experienced racial discrimination visiting a doctor or a health clinic, and that this often makes them avoid getting needed medical care. About 1/3 of LGBTQ people said that they had been told or felt that they wouldn't be welcome in a neighborhood because of their identity. So as a society, we need to acknowledge that grappling with the unrelenting stress of discrimination is a factor in terms of health. It's been shown very clearly. I know David Williams spoke at this conference a few years ago and went through the data that links so clearly racism with poor health outcomes. So let me talk a little bit about the areas that we work in at the foundation. We've got four main areas: healthy communities, healthy children and families, transforming health and healthcare systems, and leadership for better health. And each one of them connects in some way with the work that you're doing here at Purpose-Built Communities. But for the sake of time, I'm going to focus just on some of our work in creating healthy communities. And the approach that we take should sound very familiar to all of you, because we followed your lead. We followed what you're doing, and it worked for us. In 2008, we convened a commission to build a healthier America. And this was an expert body that we turned to say, if we truly want to create the opportunity for health in America, what should we focus on? Mayor Shirley Franklin was on that commission, and her insights about fully integrating community development and health greatly influenced our work and our thinking. And we continue to learn from the work of the 25 communities that are in the Purpose-Built community right now. We found that we can contribute to your work in a meaningful way by generating data. And so I wanted to go through some more data sources that we have that are available to you that you might find useful in the work that you're doing, that point to the issues of equity in communities across America. One of our first and one of the most successful that we've supported are life expectancy maps. And this is work that's been done with Virginia Commonwealth University, their Center on Society and Health. This map here is the area around where our foundation's located. So it's around Princeton, New Jersey, and Trenton, New Jersey. So in Princeton, which is predominantly white, life expectancy is 87 years. So that's the upper right-hand corner. In Trenton, which is our state capital, which is about 15 miles away, that's where the clinic I work in is located, life expectancy is 73 years. So 15 miles and a 14-year difference in life expectancy. Same state, same county, a world of difference. And it should beg the question of what's going on that's different between those two parts of our state. Over the past 3 years, we've gotten more granular when it comes to life expectancy. And we supported work that allows you to look at life expectancy by census tract. So if you go to this website, you don't need to go there now, but if you go there and you put in your address, it will give you the life expectancy for your neighborhood and will compare it to the rest of your county and your state. This project was called USA LEAP, which stands for U.S. Small Area Life Expectancy Estimates Project, and it was work done with CDC's National Center for Health Statistics and the National Association for Public Health Statistics and Information Systems. So it lets you look really closely, neighborhood by neighborhood, at what's going on. The next thing I want to talk about, I think, will be really relevant to a number of you, and it's the City Health Dashboard. It's a one-stop shop where you can get a full picture of a wide range of different factors that influence the well-being of specific neighborhoods in 500 cities across the nation. And this is factors like what sort of clinical care is available, smoking rates, teen births, lead exposure, high school graduation rates, the walkability of neighborhoods, and racial and ethnic segregation. You'll find information on 37 different measures here, and that can be helpful in decision making. I'll go through one example from Atlanta. So let's look at two different census tracts here in Atlanta. This is census tract number 4 in the upper right and census tract number 23 in the lower left. Census tract number 4 is located in the lower part of Buckhead, zip code 30309. The median household income in that census tract is $82,500. It's 72% white and 14% black. Census tract 23 on the left, it's an area that sits between Maddox Park and Washington Park, zip code 30314. In that zip code, the median income is $25,900. It's 87% black and 8% white. If you look at life expectancy between those two areas, life expectancy in the Buckhead neighborhood, 84.6 years. Life expectancy in the Washington Park neighborhood, 64 years. 20-year life expectancy difference, 5 miles apart. If you look at some of the underlying characteristics and factors that may be relevant to that, unemployment rate in census tract 4 is 5%. It's 29% in census tract 23. If you look at lead exposure risk, and this is on a scale of 1 to 10, where 1 is lowest and 10 is the highest. Census tract 4, the lead exposure risk is 4. In census tract 23, it's 9. Looking at childhood poverty, census tract 4, it's pretty much 0. There aren't kids in poverty in that census tract. In census tract 23, 49.9%, roughly half of all the children there. So, I mean, these are data points, and data can be very useful. Data don't tell the full story. It's important to get the full story. You have to be on the ground. You have to be of community and know community. When you're on the ground, that's when you learn about strengths in the community. You learn about the solutions to the problems that people see in their own communities, and you can work towards that with these data to help those solutions be implemented. By coupling data with lived experience, we believe communities can help direct public and private investment as well as community action in ways that will make a big difference. You know, we're located in Princeton, New Jersey. We're not on the ground in communities around the nation. And so much of our work is done through partnerships. And I wanted to touch on a couple of those partnerships that are quite strong and I think allow us to have some really exciting reach. One of those is with the YUSA, and I know that many of you work with the Y. I saw the beautiful Y in Eastlake. But the Y is in 10,000 communities across the nation. It reaches 22 million people. It's the sort of reach that we could never get to as a philanthropy. They're the largest purveyor of child care services in the nation. They're one of the biggest purveyors of diabetes education. And they want to be known as more than just a swim and gym. They want to be seen as an anchor institution in their communities. They want to be seen as an institution that builds social cohesion. And we know how important social cohesion is to health. And so we've been partnering with them in a big way, as I know you have been too, to help shift mindsets around what does it take to create communities that are truly healthy. I wanted to show one of the public service announcements that they put out using some of the data that we help provide.
Your zip code. Just one number different and you might have a whole other life. Different school, different job, different dreams, different problems. In America, the zip code you're born in can determine your future. The Y works to change that, with programs and services that help everyone thrive, no matter who you are or where you're from. For a better us, support your local Y today.
I don't know, when I see that, I think you could put purpose-built communities in there. You know, it's when you think about what they're talking about a community should have, it's what I hear from everyone I've talked to who's involved in purpose-built communities. You know, another key partner for us, a new partner for us, is the NAACP. They have 110 years of legacy in communities, that building roots that give residents agency and leverage to make change. And people say, well, why is a health philanthropy working with the NAACP? Well, we see civil rights and civic engagement as critically important to building a culture of health in America, for changing how people think about health in America. And we see no better partner in terms of engaging around civil rights and civic engagement than the NAACP. Oh, that's our logo. I'm behind the slide. All right. Well, I hope you've gotten a flavor as to why I'm so excited about the work that we're doing with all of you. Like the Y and the NAACP, you're highly respected voice in the communities in which you're working. You're breaking down silos. You're taking on really hard, challenging problems and having those conversations that are so critically important to changing the fabric of our society in a healthy way. You're leading the way in creating communities where everyone has a fair and just opportunity for health and well-being. So let me close by saying again that what you're doing is nothing short of revolutionary, and we are truly honored to be part of it. We applaud what you're doing in the biggest way. In fact, we are going to be bringing our board here to Atlanta in 2 weeks, primarily because we wanted to see what's going on in Eastlake. We think that will be very valuable to us as we're having conversations in our boardroom around what kind of America it is we're looking to see. We want to change how people think about health and what creates or limits opportunities for healthy choices. We want to work towards policies that change America in ways that remove barriers and create opportunity for all. We're going to continue challenging ourselves and those we collaborate with to recognize the direct connection between health, well-being, and these big thorny issues of equity. One of the things that we do, we continue to ask ourselves, who is benefiting most from our work? Whose life experiences are missing from that work? And how might that skew our efforts and our outcomes? Because we truly believe that together we can build a nation of communities where everyone has an opportunity to prosper and thrive. So thank you for allowing me to speak to you today. I'm truly inspired by your work.